protection, and the promise of the second chance. For this, we would like to invite on the stage Dr. Uday Sanglodkar sir and his Max Nanavati team. And I also request Dr. Uday Sanglodkar sir to introduce his team to the audience.
Those who are sitting at the back, please come forward. Dr. Darak, those who are sitting at the back, please come forward. It is going to be a very good session. Please.
And Valsad ISCCM Society for giving us this opportunity to discuss more on transplant hepatology. We are going to discuss about hepatology and critically liver diseases, mainly focusing on acute liver failure and acute on chronic liver failure, and the role of liver transplant at the same time. So we are going to discuss on the three topic, as I said, ALF for the first panel discussion. I would like to call upon Dr. Jaideep Topiwala, Dr. Praveen Borsadia, Dr. Radhika Ruhatia, and Dr. Aditya Nanavati. So I'll briefly introduce Dr. Praveen Borsadia. He is a gastroenterologist at Surat. Dr. Jaideep Topiwala, he is an intensivist at Surat. Both of them are at Vedam Hospital. Dr. Aditya Nanavati, he is a senior consultant surgeon, HPB surgeon and liver transplant surgeon at Nanavati Max Hospital in our team. And Dr. Radhika Ruhatia, she is our chief intensivist at Nanavati Hospital, who dedicatedly takes care of liver ICU and liver transplant ICU patients. To start with my first panel discussion, can you start? Thank you. Hello everyone, good morning. So this is a basic scenario what we are going to discuss. To start with, so this is a typical scenario of 21 years old male who is 60 kg. He had typical prodromal symptoms and jaundice 2 weeks back. Now he has developed altered sensorium. Total bilirubin is 14. INR has gone up to 6.5 after 2 weeks. Serum creatinine is 0.8. So everyone can gather the information that this is a typically acute hepatitis and acute liver failure because there is a hepatic encephalopathy as well as the INR has gone up more than 6.5. So my first question to Dr. Jaideep, when to suspect acute liver failure whenever there are patients who are coming to the ICU or to the hospital?
See history properly. In that scenario, patient symptoms like abdominal pain, right upper quadrant pain, anorexia. And second thing, with altered liver function, with any etiology like viral or something ischemic, or maybe due to paracetamol ingestion. And in acute liver failure, the criteria says that a patient have altered liver function with coagulopathy.
Right.
And with encephalopathy.
Correct.
Within, before any past history of liver function, that we can say acute liver failure.
Correct. You're absolutely right. So there is a huge difference. Whenever there is a hepatitis, first of all, the definition is there is a rapid development of hepatocellular dysfunction, which includes jaundice and coagulopathy with hepatic encephalopathy. Patient should be having altered sensorium in absence of prior history of liver disease. That means he was absolutely fine walking, talking, but suddenly he has deteriorated. So that is called as acute liver failure. So exception to these definitions are there are 3 ALF phenotype. Even if they have underlying liver disease or they are known to have a liver disease, but their first presentation can be considered as a acute liver failure, which is Wilson's disease, reactivation of hepatitis B, and autoimmune hepatitis. So what is acute liver injury? All the features in absence of hepatic encephalopathy we called as acute liver injury. When to suspect, you need a very high index of suspicion for these patients. History, exposure to viral infection, drug, toxins, and absence of chronic liver disease is must. Clinically, they may have prodromal symptoms, right upper quadrant pain, jaundice. Most importantly, daily mental status examination and change in behavior. This is a patient who is lying down, he has diagnosed with hepatitis A, he is stable for 3-4 days, now suddenly he has developed altered sensorium, that means he has gone into a liver failure. So what are the sudden worsening of clinical parameters which we should always see in all the patients? If there is a sudden tachycardia, hypotension, oliguria, drowsiness or new onset of ascites, that means he is heading towards acute liver failure. So what investigations will you advise to prognosticate this patient? Dr. Praveen?
So to prognosticate all the investigation, arterial lactate and creatinine,
Correct.
all are important.
Correct. We should have these all parameters in place. All the patients where we are suspecting that he may go into acute liver failure, these all should be done. So INR, ammonia, increasing serum creatinine or ABG, that means lactate if it is available. AST, ALT is not specific, but yes, if it is disproportionately high, like in more than 5,000 or 10,000, then there is a high possibility they may land up into a acute liver failure. Having said that, with all these blood parameters, there should be altered sensorium. So Dr. Radhika, when will you think of transferring this patient to transplant center?
So if there is some hemodynamic grade 1, grade 2, we'll think of transferring this patient to a higher center.
It is more than 1.5 along with altered mental status, or there is a sudden deterioration in the hemodynamic status. The reason, because as ALF patient needs advanced hemodynamic monitoring to reduce cerebral edema, control hemodynamic fluctuations and airway protection in case of worsening encephalopathy. If undiagnosed and untreated, the mortality is up to 80%. So that's the reason this patient should be shifted to a transplant center. Now, this is the same patient on day 2. He slipped into a grade 2, grade 3 hepatic encephalopathy, now intubated. His blood pressure is 100/70, heart rate is 100 per minute. He needs a central venous line and arterial line now. Platelets are 90,000, INR is 6.5, and fibrinogen is 120. So, Dr. Praveen, does he need a correction of coagulopathy at this point?
So
Because his INR is 6.5, platelets are 90,000, even the fibrinogen is low.
for coagulopathy is not warranted. Actually, whenever there is an invasive procedure required, like arterial line insertion or intracranial pressure monitoring, which practically we are not using here.
Right.
But if such invasive procedures are required, then only preemptive coagulopathy correction is required in this type of patient. Because even if INR is high, but still these patients are at low risk of development of spontaneous bleeding.
Correct. So when it comes to uncommon, less than 10%, routine use of FFP should be discouraged. FFP masks the trend of INR, which can be used as a prognostic marker, because which is the only marker which is included in the King's College criteria, which prognosticates. If you are giving FFP, the INR value will go down, and they will not be able to prognosticate the patient or assess the severity. Injection vitamin K should be considered in all cases. Blood transfusions in case of active bleeding or need of ICP monitoring. Even for central line insertion or your arterial line insertion, there is no need of correcting the coagulopathy in those patients, except if they are actively bleeding or they are hemodynamically too unstable, and if we are planning for the ICP monitoring. So if you are putting a ICP monitor, which is actually absolute nowadays, no one does that, then the target should be INR less than 1.5, platelet more than 50, and fibrinogen more than 100. This is only in two conditions: if you are putting intracranial bolt or the patient is bleeding. Ideally, thromboelastogram, that is TEG, if it is available, should be done. That gives you a correct idea of functional status of the clot or the bleeding condition. Dr. Radhika, when do you consider 3% of NaCl in those patients?
Grade 3 HE, at that time we'll consider 3% NS.
Right. What is your take, Dr. Aditya, on this? 3% NaCl?
You're asking the wrong person. My take is to defer to my intensivist.
Good. I like that answer. So, neuro 1 or grade 2 hepatic encephalopathy, The treatment is avoid stimulus, avoid sedation, safe transfer to liver transplant unit. If you have slipped into grade 3 or grade 4 hepatic encephalopathy, then elective intubation and deep sedation. The elective intubation is basically for the airway protection, otherwise the risk of aspiration is very high. Hyperventilation, elevation of bed height to 30 degree, temperature, euthermia can be maintained, pupil monitoring early. This is the easiest and easy tool to do every 1 hourly by the same person if possibly. Hyperosmotic solution like mannitol or 3% NaCl should be used in all those patients when the grade of encephalopathy is higher. There is no role of prophylactic antiepileptic drugs, but there is a lot of time confusion that shall we prophylactically give antiepileptic, but there is no consensus on that. But guideline says there is no requirement of antiepileptic drugs, and patient may need induced coma, that is phenobarbital or thiopentol sodium in some resistant cases.
So, one question.
Please, please.
Regarding this 3% saline, to prefer.
So, Dr. Radhika, can you answer that question? She is our intensivist.
So if there is no renal dysfunction, you can give mannitol even as a bolus dose and start a continuous infusion of 3% NS. If you are using a isolated 3% NS and if your sodium levels, depending on your sodium levels, if your sodium levels are 140, 142, you may avoid a bolus, or if your sodium levels are 130, but your target should be like between 8 to 6 MEQ per day correction.
So ideally the target should be 140 to 145 whenever we want to give. Boluses, mannitol is preferable, sodium are better because you can titrate the dose, you can increase the dose, and you can every 8 hourly we do serum sodium levels in those patients.
What is your take on use of N-acetylcysteine routinely?
I'll come to that on the treatment. So what measures will you take to reduce the ammonia in ALF patients? Anyone? Dr. Jaideep? Lactulose syrup, lactulose enema, rifaximin, or L-ornithine aspartate, LOLA?
According to studies, rifaximin and LOLA have no better any outcome yet. But the lactulose syrup we may use. But the only issue is sometimes they not properly work, but gaseous distension and may land up in some trouble.
Right. So,
can I?
Please, please.
Actually, in acute liver failure, none of these are effective.
Actually, yes, you are right, sir. You are absolutely right. So, coming to your question, Mayank sir, yes, in all the patients with acute liver failure with transaminitis, this patient should be started on N-acetylcysteine. There are no set protocols. You can use a paracetamol protocol. This protocol of 150, then 50 and 100 is typically used in ratol poison and paracetamol poison. But in other cases, viral cases and all, you can use 100 mg per kg of infusion over 5 days. So N-acetylcysteine should be used in all the patients. Routine use of rifaximin, there is no role. Routine use of oral lactulose, as sir said, Dr. Praveen said, it is doubtful. L-ornithine aspartate, definitely no role. But in ALF, there is a LOPA, L-ornithine phenyl acetate, but it is not available in the India. It has been used in a few centers all across the world. Steroids, there is no role. So now this is day 3, same patients. He is getting vitally unstable. He is tachycardic, 130 per minute of heart rate. BP is 100/70. Now he is requiring minimal inotrope. INR is 7, fibrinogen is 100. Total count is normal, CRP is 56. So there is no growth in the cultures because day 3 on day 0 we usually send all the cultures. What would be your antibiotic policy and would you give empirical antifungals in all ALF patients? Dr. Radhika?
Generally, there is no role of prophylactic antibiotics in ALF patients. But if we are planning any extracorporeal therapy in these patients in the form of CRRT or plasma exchange, or if there is hemodynamic instability, then we may consider adding a beta-lactam antibiotic. If we are planning plasma exchange or CRRT, then we may add a antifungal.
Correct. So ideally, there is no role, but prophylactic antibiotics should be used as per hospital policy. Intravenous catheter should be changed every 5 to 7 days. Remove urinary catheter if the patient is anuric. Role of antifungal is not proven, but if there is a new onset of shock after 2 or 3 days and which is not responding to antibiotics, antifungal should be added. Unexplained hypotension, oliguria, worsening of hepatic encephalopathy, increased acidosis should be considered as a sign of sepsis, and antibiotics should be escalated. By the end of the day, on the same day 3, his ammonia went to 170, which was 86 on admission. ABG, lactates are creeping, 5.6 now. Urine output is borderline, 60 ml per hour. Pupils are 2 mm equal and reacting to lights. What next? Anyone? Dr. Jaideep, Dr. Praveen? Will you continue the same management, what is going on, or you will start the patient on CRRT, plasma exchange, or CRRT and plasma exchange both?
From this till date, we get a high ammonia level and high lactate. That means no clearance we achieved. So CRRT may be helpful for clearing lactate and ammonia level too.
What about you, Dr. Praveen? Will you prefer CRRT or Plex plasma exchange?
Plex and CRRT both.
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 Okay.
It would be
So,
as a
Dr.
bridge to transplant, because this patient is worsening rapidly. We should evaluate for transplant also.
Correct. So, role of CRRT and Plex, I won't go into detail. Dr. Radhika is going to give you a brief about what is the CRRT and Plex in ALF. But to brief you, AKI is common in 40 to 80% of patients in ALF. There should be low threshold for starting renal replacement therapy. CRRT is always preferred. It is useful to clear lactate and ammonia. There are no clear indications of timing of CRRT. However, patients with oliguria, hypotension, rising lactates, and arterial ammonia persistently more than 150 can be considered for CVV-HDF. High volume plasma exchange can be used in patients with persistent SIRS and high ammonia level, but it is as a bridge to transplant. It is not a definitive cure because there are no randomized trials and head-to-head trials for CRRT versus plasma exchange. So, bridge to transplant, where does plasma exchange comes? It is a bridge to transplant. Therapeutic plasma exchange has proven role in ratol poisoning. It helps sometimes in controlling the SIRS when you need optimization of the vitally unstable patient before the transplant. And renal replacement therapy, definitely it is a metabolic replacement device. It helps in reducing the ammonia level, reduces the acidosis, and it helps in optimizing the patients before liver transplant. So, Dr. Aditya, I think last and final question for you. When will you advise a liver transplant in ALF?
I think irrespective of the criteria, when I feel that the liver dysfunction is irreversible or there is a imminent risk of mortality to the patient from cerebral edema or irreversible neurological injury is when I would actually advise transplant. I think blurring with extracorporeal therapy, we have seen people recover from the brink of disaster with INRs of 10, unrecordable INRs also recover without needing a transplant with, the armamentarium now becoming so extensive. So I think as experience improves, the only reliable indicator remains either irreversible liver injury, that is continued deterioration despite maximal medical therapy, or imminent neurological injury resistant to all medical therapy. That's when I would go in for an early and expeditious transplant.
Is there a difference between routine liver transplant, which we do for chronic liver disease patient, versus a patient who is acute liver failure, and both of these patient needs a liver transplant? Is there a difference when it comes to ALF?
Yes, so definitely the patient is more. So the metabolics have to be mindful of. Our management protocol definitely changes in terms of assessing neurology even right before going to OR. Before wheeling into OR, our routine practice is to take patient for CT before just to be sure that he's not herniated. So yes, there is a significant difference between a chronic liver disease patient and an ALF patient. But I think in an experienced transplant unit, it would be just a routine day.
Right, correct. So yes, these patients who are not, second is there is non-paracetamol poisoning cases. The criteria says the important parameters are INR, bilirubin, creatinine, etiology of the patient, age of the patient, and it's very easy to use this formula in day-to-day practice. If you have ALF cases, the specificity and sensitivity is almost more than 80% in all those patients. So if they are deserving this criteria, they fulfill this criteria, this patient needs a liver transplant. Liver transplant, yeah, please, sir.
Hello.
Yeah.
There is some flaw in using King's College criteria also, because these criteria were developed in UK, where the etiological factors are different from India. In India, most common, up to 70-80% of cases of acute liver failure are viral hepatitis A or E, while in UK it is uncommon, yeah, less common. So this is again flaw. And another thing, even if they mention ALF due to other etiology other than acetophenone toxicity, the 3 out of 5 criteria they mentioned should be present. So that is okay. If the 3 criteria are present in an if patient not transplanted, the mortality was around 80%. That is why
Right.
they have included 3. But even if less than 3, that is 2 criteria are present, and these patients do not fulfill the King's College criteria, but still, even if 2 criteria are present, mortality is around 30% or 40%.
Yeah,
So there is
absolutely.
a flaw to this KCC criteria.
So actually, for Indian patient, this King's College criteria has not been extensively studied. In India, in North AIMS, they have, you know, studied about all ALF patient, including viral etiologies. There is a ALFED model, ALF model, what is called. It is a dynamic model. Day 0 and day 3 you need to calculate. The problem is, this both the criteria includes INR, and whenever we get a patient at our center, these all the patients have received FFP. So their INR is masked by the FFP. So it is very difficult to say. It's always a clinical judgment at the end of the day when you need to advise a liver transplant to these patients.
What is the duration? Means if you use FAP and patient has been shifted to your center,
there
up
are
to
no
what
studies.
level your INR can be masked?
So there are no studies. What we called as delta INR, we need to calculate. If you have done a plex, suppose a patient's INR is 3, you have done a plasma exchange or you have given a FFP to that patient, the next day you see INR it is 2.5. But on day 2, subsequently, if the INR is jumping more than 3 again, which was baseline when we started plex, that means the delta INR is very high. That means he is not responding to treatment, whatever you have tried. But there are no studies about that. So that's why the FFP should be avoided in all the patient if possible. And same goes for the plasma exchange.
No, my question is there any specific time period, just for my knowledge? Because suppose your INR has been masked, so after 24 hour, 48 hour, and if INR means what is the duration?
So we
after
don't know. We do
48
it well early. INR and ammonia and lactates are done, and depending upon all 3 parameters, not only INR. If ammonia going up, lactate going up, at the same time INR is also going up, that means he is not responding.
No, for selection of transplant.
No. It is only for deciding or to avoid the transfusions. Moreover, it has been used to avoid the transfusion rather than to transfuse the patients. So this is my summary. Most of the things we have discussed. I call upon Dr. Radhika to discuss more on role of extracorporeal therapies, that is CRRT and plasma exchange in acute liver failure patients.
Well, just before we conclude, one important thing that your summary slide also showed is that discussion with the family. I think our intensive care colleagues do a very good job of actually initiating this discussion pretty early in the course of the patient, because it's impossible to say at admission which patient will go for transplant and who will respond to conservative management, even though there are some early prognostic markers. But sometimes it's better, and in your when your question you asked what is different in the ALF management, I think one more important part is early evaluation of a donor, early preparation of a transplant, and then selective or judicious use of the transplant.
Right.
Transplant may not be for everybody, but it's better to be prepared for everybody.
Absolutely. So as a referral center, he has pointed out the thing which is what we see in our practice. As a referral center, we see patients of ALF coming on day 7, day 10, where they are already on triple inotropes. They are already acidotic, and we have to optimize those patients, and already it has been delayed. The most common reason being aspiration pneumonia. These are the patients where encephalopathy was there, but the patient was not intubated for airway protection, and now they are with the sepsis, and it is very difficult to transplant acute liver failure patient with full-blown sepsis.
Another thing I want to ask, sir, in one of your slide you suggest one of the therapy is steroid for AIH-induced ALF. So my question is, will you use steroid for DILI-induced ALF, drug-induced?
Until and unless we do a liver biopsy, we don't use steroids. So when it comes to drug-induced liver injury, there are types. So this can be DILI-AIH, drug-induced liver injury-related autoimmune hepatitis, where 3 months of short course of steroid has proven a good benefit.
In ALF, suppose in ALF, if it is not AIH, we have proven it is ATT-induced ALF.
We don't do. We don't give. But if family is not willing, it is more of like a palliative care, then we do liver biopsy, prove it, and then only we'll give. But we will routinely not give. What do you think, sir, Mayank, sir? Yeah, yeah.
No, routinely we don't give for steroids for the, at least in ALF.
ALF, yeah.
Importance of serial ammonia level in prognosis?
Hello. Yes, so serial ammonia level monitoring is used, and that is what he mentioned in alpha that is rising from day 1 to day 3, or the ammonia level is more than 125, I think, more than 120. So these patients are going towards, these patients cannot be survived usually without liver transplant. So serial ammonia monitoring, yes, definitely is helpful.
No, but if many patients we found that prothrombin time remains stable or near 1.5 or 2 times, and sometimes only ammonia is rising. So is there any importance?
So I'll answer to your questions. Patients with acute liver failure, until and unless patient has altered sensorium, there is no role of doing ammonia levels.
No, in altered sensorium, in
Definitely, then you should do.
grade 1 and 2 hepatic
So
encephalopathy.
definitely, once the patient is labeled as ALF, ammonia level should be done every 12 hourly, because if serial rise in ammonia is not a good sign.
But what I am asking, if prothrombin time is remains stable over serial PT is remaining stable, but only ammonia is rising. That is my question.
Correct. So we have to act. We have to act if the patient is encephalopathic, INR remaining stable, and only ammonia going up. The ideal would be immediately we should start him on a CRRT.
And what is your practice? You are not using lactulose in your patients
No,
of hepatic
we don't use lactulose. We don't use rifaximin.